Okay, so we're very pleased today for this webinar called Hope in Action, Tools for Understanding and Preventing Suicide, to have Dr. Adam Ligas with us. He's board certified in adult psychiatry, addiction psychiatry, and forensic psychiatry. He's got both direct and indirect clinical experience, and he's a medical director for Lucet for both commercial and Medicare Florida Blue members. And with that, Dr. Lucet, I'm going to turn it over to you.
Hi, that's great. Great to see you all virtually. I'm Dr. Adam Ligas, and we are going to have the Hope in Action, Tools for Understanding and Preventing Suicide. And I hope you all had an opportunity to get that wonderful quote from the beginning of this webinar, where hope is not a limited resource, it's renewable. And if we wake up the next morning, we can have more of it. I'm paraphrasing, that wasn't exactly the quote, but that's my paraphrase. So I do want to start with our disclaimer. And the disclaimer is that the content found in this presentation is for informational purposes only. I am a psychiatrist. I'm not your psychiatrist. So none of this is related to treatment. The content is not meant for as a substitute for medical, clinical, legal, or professional advice on any of the subject matter that's here. Lucet makes every effort to present complete and accurate information. We do not make any warranties or represent does not warrant or represent the accuracy, completeness, or timeliness of the information. So getting that out of the way, we're going to be going through this overview as a roadmap. And before I do that, I just want to acknowledge this conversation may be challenging for some of you. And there may be individuals in the room that may have had their own struggles, or know individuals who have been struggling with suicidal thoughts or feelings. Want to make sure to acknowledge that you're not alone. Nobody's alone. These are thoughts, feelings, emotions, and they do happen. Want to make sure that everybody's really getting an opportunity to take care of your own well-being. And so if there are any proactive strategies that you'd like to engage with, please do so. Utilize the Q&A in order to ask any questions in order to catch up. If it is necessary to reach out to a trusted friend, family member, or mental health professional related to what's turned up related to the content here, please make sure to do that. There are additional resources that are available, including crisis hotlines, the 988, make sure you're safe, that's an option. And of course, if there arise any immediate concerns, always can use 911. We'll get into more resources at the end. This webinar is for general purposes again, and we're not going to be providing any specific advice. General advice is general, and there is no one size fits all, one thing that if done for every single person has the same results for every single person. And so nuances are part of all of us as individuals, but when we're talking something as complex as suicide. So just want to make sure that there's that awareness. If you or anybody that you know is struggling with suicidal thoughts or feelings, it's essential to engage with qualified healthcare personnel in order for the assessments to guide the treatment, if there's treatment that's warranted, and to provide the necessary supports to what's going on. Again, I'm here for general information and resources. If you need to take a break, please do so. Your well-being is our top priority, and it's one of the reasons that we're pulling together this information here in September, as Suicide Prevention Month. So just wanted to take that opportunity to go through that. As part of today's conversation, we do have some agenda items and the roadmap. We'll make a stop at the public health impact of suicide. We'll continue on to discuss some risk factors and warning signs, and there may be some differences that'll pop up in risk factors for adults and adolescents, how to help an individual with suicidal thoughts, and then concluding with some of the resources. Want to make sure that understanding that suicide is a serious issue. Suicide is preventable. Knowing what those warning signs are, how to make offers of help, how to provide that help can really make a big difference, and it can even save someone's life. So we really think that this is relevant and important information. So the public health impact in the United States of suicide is strikingly clear when we look at the most recent evidence in 2023. The statistics are showing that suicide is one of the leading causes of death in the United States. And when we're saying leading, depending on the way the information is broke down, could be top three. So this is a critical area to address. When we're thinking about numbers, 49,000 people died by suicide in 2023. 12.8 million individuals seriously thought about suicide. And you can see that there's a big difference between individuals who are thinking about suicide and then the people who die from suicide. The challenge here is that if we dug into that 49,000 people, I don't think we would find any that didn't have a thought of suicide prior to engaging in suicide attempts. And we would say that the 49,000 people successfully completed suicide. 3.7 million, so 12.8 million had thoughts, 3.7 million made a plan now, and then 1.5 million attempted. So we can see that the numbers continue to drop, but it's that 1.5 million attempted and the 49,000 where the individuals died. And so if we can make interventions by decreasing the individuals who think it, decreasing the individuals who plan it, decrease the individuals who attempt it, we're certainly going to decrease the individuals who completed it. So one of the challenges when talking about suicide is that it is a very complicated and nuanced thought, plan, intent, attempt kind of chain here. And so there are risk factors that will speak to an individual. There are risk factors, acute risk factors. So let me just quickly say, so when we think about risk factors, the word acute means really immediate and a clear departure from somebody's normal, something that's brand new and also pretty significant. When we think about chronic, we think about those things that did pop up and continue to pop up and are likely to pop up down in the future. And then when we think about the risk factors, we can think about different domains or categories related to those risk factors that may speak in the community. What are those areas in the community that may be there that are new and different? And what are those things that are there pretty consistently? What are there in the individual, new and different, and they're pretty consistently societal, and then also relationship? Because none of these categories are there in a vacuum, or they're on a single timeline that says that what's there right now will always be there in that way without any change. So that becomes very critical when we're thinking about these risk factors, because there's some of them that are going to go away, and there's some of them that are going to get better over time without any intervention, that if we just gave it time and we're able to sit on it, things could be better. There are also things that we can actively do with the time in order to increase the likelihood or increase the opportunity for things to go away. I think it's going to become kind of clear as we start talking through those, but just wanted to get those concepts forward while we're thinking about acute. So some acute factors, many of these can say that these are acute stressors, or that these are stressful events that occur. So job loss, huge. Divorce, and then legal troubles. These are three really we would typically identify as these are life-altering events. And when we start thinking about life-altering, we then start to really increase the concerns that an individual, before their event, what they saw their life look like, and then after the event, happen, what their life will look like can fundamentally change. The reason why these risk factors are so important is that individuals with there are individuals that their hope gets drowned out. Their idea that they can manage, withstand, cope with the circumstances that are in front of them, the interpretation of what other individuals or even them themselves is going to see as themselves moving through life can fundamentally change with the way that these events occur. So it's in the aftermath of these events that you may see individuals who have really high levels of stress, and because these events don't happen all the time, they're not regularly there, it may challenge their ability to cope with the situation. So if you're hearing me say that suicide is rarely a single circumstance or event, it also means that the events themselves are in a crosswalk or a matching with the ability to cope. There's terms that are thrown around like resilience, effective coping skills, stress management, that these are some of the terms that allow individuals to, as a stressful event occur, be able to meet that stressful event where they don't feel overwhelmed. Because one of the areas here is that feeling overwhelmed tends to be a very, very significant component of suicidal ideation. Feeling overwhelmed and not being able to cope, losing hope that there's light at the end of the tunnel or opportunity to address the situation where the circumstances are going to improve. Those are recipes that tend to evolve into an increased likelihood of suicide. And I'm using the word suicide broadly because suicidal ideation is one way to look at what is the risk, right? If I'm not having any thoughts at all, my risk of suicide is very different than if I have all of a sudden a thought of suicide. What my plan or the way that I would be thinking if I do have an idea about suicide, how I would think about committing suicide, and then my intention to commit suicide. All these things roll into to the risks related to suicide. In terms of the action, these are the events that may precede it, and it all goes into a bigger theme of risk assessments. I'm trying to keep things in again that more general sense, because if any of you are starting to think like, wow, that sounds like a whole lot, I don't know if I'd be able to do that, that's actually really good, because this is where the involvement and engagement with professionals and individuals who are experienced in assessing for suicide risk, managing suicide risk, treating risk factors for suicide risk, and being able to create a comprehensive plan in order to continue to evolve the treatment and management of suicide risk. That's where the professionals come in. Because when we're moving to the next one, which is chronic, this is where professionals are also often highlighting what some of these chronic risk factors are. So mental health conditions, there are certain mental health conditions, a diagnosis of a mental illness that can change the way that the brain operates, in the way that it incorporates information, and then the way that it takes the information and is able to package it into a clear picture, and then the way that the brain and the body interact in order to cope with those situations. Depression is the one that tends to come up the most, because individuals who are helpless, who feel hopeless, who feel like there's not, and that individual certainly sounds like they are profoundly depressed. When we use the word, when I'm using the word depression as an illness, this is somebody whose depression has been there at a sufficient degree of intensity for a sufficient duration of time and has been diagnosed as a condition. And because that condition is there, there's going to be treatment options that are going to be available. The next one would be a history of suicide attempts. And let me just say this. The data continues to show that the greatest risk factor of somebody engaging in a suicide attempt in the future is whether they had one in the past. So if we're able to engage and intervene with an individual where they've never made a suicide attempt, we decrease their risk in the biggest way of saying this is somebody who's at risk of future. Now, the hard part here is, well, sure, doc, but what about, how do you ever get to the first one? And that's where there's a challenge. But anybody who's had a history of suicide attempt and is starting to talk about suicide, we would want to make sure. We would want to make sure that we're taking things very, very seriously, and ensuring that any of the return or any of those ideas that would be a change that we would want to talk to professionals in order for interventions to happen. Substance use. The way that substances affect individuals is also complicated. There is a direct correlation and a connection where somebody who is intoxicated, it could change the way that they think about suicide. It also increases the likelihood that individuals who are thinking of suicide may impulsively act on suicide. Substances, when people are intoxicated or in the aftermath of consumption or with chronic consumption, regular consumption, individuals can have their moods change. And new illnesses can start to crop up where an individual who's using substances can now have a substance use illness. The way that substance is now negatively affecting their life can continue to create problems where their life, now that they have this illness of substance use, may be very different than when they were just having fun on the weekends or engaging with social events, or the people who were there that were like really enjoying that person who was the life of the party now are saying, like, I don't know if I really want that person at the party, because every time they're here now, there's some kind of mess that's happening. These things can change where, again, individuals who are engaging in the substance use, it can take on a life of its own that also changes some of the factors that are going on here. So in the domains, I think you've also heard that there are threads that start pulling into community, that go into some of the individual factors, but there are also societal factors. And one of the things that we see in terms of risk factors is that if somebody's in a group, a culture, a school, a community, a family where there's a suicide, and somebody has attempted or successfully completed suicide, the risks go up for everybody in that community. The more that suicide is promoted in news and media, we do see creeps up. We do see a creep up as far as that goes on. And this also goes, this may be surprising for some, we also see this in terms of suicidal behaviors, even in treatment, where in the milieu of individuals, if we start seeing escalations, it tends to lift the entire unit up. The point there is, as we start to think about ourselves and about our loved ones and about the individuals that are in our community, we can see that, we can think about that as a part of connection, where it may offer us opportunities if we're seeing something going on or if something happened, to really create opportunities for communication in order to discuss what's new, what's there, what's different, where's this coming from, and then in order to address through interventions. Just make sure I check my note here. So I think that there's a real question there that says, well, Dr. Ligas, isn't anybody who commits suicide mentally ill? Or isn't anybody who attempted suicide mentally ill? And the answer is not necessarily. Because individuals, so mental illness or an individual who carries a diagnosis of a condition, it's one, again, over a severity, an intensity, a duration, and also ruling out other things that go on. And one of the difficult pieces here is that some of the individuals that are most at risk for acute suicide attempts as their first attempt do not actually have a preceding psychiatric condition. The psychiatric condition may have evolved where they may now newly have one, but the circumstances that occurred in their life, that acute, very drastic, significant life event, so it could be death of a loved one, job loss, divorce, legal troubles, those things that say this thing that now happened, it changed my life and not for the better. It changed my life for the worse, and I don't know how I can live now that this thing changed. Anytime that kind of comment is there, we should have our feelers up and say, I might need to ask about suicide. And even if we said, well, that person's never had a mental illness and I've never seen them this sick before, we don't have to think about that. We just think that this is somebody who's going with something that is life changing for them for the worse, and is starting to give me the picture that they're not sure how they're going to be able to get beyond that. That could kind of get our feelers up. It could evolve. They could, because of this event, and stressors are a trigger to mental health conditions, mental health illnesses. This could be the one that then causes them to have the illness. Even if they've never had it before, it doesn't mean that this isn't significant. I hope to touch that well. Again, it's complicated, and this is where professionals, not me talking in front of you, not any of you out there for your loved ones, family members, community members. This is where professionals can come in order to do the assessments to determine if it's there. And if it's not there, it doesn't mean that a person is 100% completely safe. It just means that there may be other factors that are more relevant to look at than we're treating an illness here. We may be treating an event here. We may be managing a stressful circumstance here. I guess that's enough time on the slide. Okay, so talk about risk factors. Now we're going to talk about the prevention strategies. And so one of the areas here is want to strengthen access and delivery of suicide care. Suicide care is ensuring that we have the right supports. The supports also mean safety. There are times that the number one most important thing that we need to do for somebody is to remove them from having access to something that they impulsively can use in order to do something that they haven't really thought through, that they're acting in the moment, and that moment has high lethality. So one of the biggest prevention strategies is removing access to the high lethal means. The high lethal means are firearms and overdose to substances that are highly risky for overdose, and then hanging, especially in certain populations. So certain populations would be individuals incarcerated, higher likelihood, or individuals who are hospitalized. I want to stress this. Decreasing access to highly lethal means is critically important and may actually be the most important strategy to avoid suicide in general. There's an idea that somebody who wants to do it will do it no matter what. That idea is not the common norm. The most common way that individuals are is, I'm thinking about doing it this way right now. And if I don't do it, I might not be thinking about it again. That's the more common one. And so the more that we think, the more that we believe, because it's accurate in terms of the data, that individuals can get through this and then be on the other side of it, the more accurate and actually the more intentional we may be in some of the ways that we prevent. So sitting with somebody, spending time with somebody, keeping them away from those things, ensuring that they're in a safe place with safe people, again, in that safe environment, they're critical, and they can make a huge difference, because we don't know what sometimes these thoughts happen. Again, somebody has the event and then they start to think about this, they feel tremendously overwhelmed, and it seems like when they went from 0 to 100 in several minutes. Somebody can get there that fast, they can also come down. And so in several minutes, with containment, support, safety, individuals can actually de-escalate. Watching and seeing the changes are really good, and there are highlights, and simultaneously individuals still may require the additional care and support. And so thinking about, what do I need to do in order to get this individual connected for a full assessment, in order to evaluate all the relevant factors that are going on here while simultaneously creating safety? That's a critical component here. We want to promote connectedness. Individuals who, if for individuals who have attempted suicide and then said kind of like what was going on when that was happening, feeling of isolation, loneliness, that they're the only one that's going through this, that there's nobody that's ever going to understand this, and that they're feeling like they're on an island is hugely common. And so being able to connect individuals and allow them to express what is occurring in a way that facilitates a ownership, acknowledgement and ownership, a connectedness, and the assistance related to the people around them can make a huge difference. This does address hopelessness, where sometimes the people are thinking that there's no hope, that they're always going to be alone. It is already solving an issue, which is they're not alone. There are also opportunities through the connectedness to be able to model and engage with effective teaching, coping, modeling skills. And also through that connectedness can identify the support people, as well as evaluate and understand what some of the risks are. So I'm going to pause there for a second and get myself a sip of water. That's coffee. Okay. So if somebody's sitting there and says, wow, I probably have to be ready in order to have the conversation with a person, you're right. And so let me make sure. Yeah, you're right, because when we're evaluating and talking to somebody, nobody can read minds, right? At least nobody has the skillful ability to read minds in a way that, as elucidates suicide, and say, well, just do that and read. We're going to get that person to read minds in order to avoid suicide, which means that we always have to get somebody talking. And in that talking, we also have to be able to listen, hear, and acknowledge. Because one of the there's kind of a do's and don'ts that goes around. There's the do is ask about suicide, and you can always ask whether somebody, if you're concerned, if your gut is saying, your idea is saying, you're saying, I heard this talk, seems like this person has a life event, they're saying that they don't know how to get around it, and you ask them, hey, I'm from a loving place, really concerned about you. Are you have any thoughts about killing yourself? That question, coming from a loving, caring place, concerned place, is never the wrong answer, because the worst thing that's going to happen is the person's going to get upset and say, why would you ever think that? You could say, I thought it. I just wanted to make sure you were safe. I love you too much to not ask. The risk of pushing them to suicide isn't real. The data continues to show that asking about suicide moves individuals more towards prevention, non-action, and addressing than it does ever saying, you asked, now I'm going to tell you, and that means I'm going to do it because I said it out loud. The internal monologue, or the way that people talk to themselves, may be very different when they hear it externally. And so actually saying things out loud and hearing ourselves say the things that we sometimes are thinking, that is actually a coping strategy for certain types of issues. And so having somebody say it out loud doesn't move them to it. It doesn't like write it in stone and all of a sudden create that. The opposite, it actually now starts to create an opportunity to start unraveling some of the way that they got themselves tangled up in order to get things more safe. We have to be able to hear that somebody that we love, that we would never want them to do this, might be thinking about something that we would never want them to think about. And to be able to accept that without demeaning, diminishing, or removing the circumstances that say that. Because if somebody's life, if their concerns, if their feelings, their emotions have already gotten to the point where they're thinking that life may be not worth living, it is not really in my place to judge them and say, but by the way, aren't you going to look at it the way I'm looking at your life and everything's pretty okay? Because they're the ones that are in that moment. And so I may have to have that patience and the tolerability, the opportunity to graciously hear what they're saying without refuting it, removing it, undermining it, or trying to argue with them on that. I may, in the future, when they're not in that state, be able to create some discrepancies and say, hey, by the way, you said that things were so awful, and simultaneously this, that, the third job, loved ones, you still got all these things. Maybe you're going to write the best country song in the world because look how many people have made millions of dollars that way. There's always going to be those opportunities. It's not really right in that moment. because we're really starting when we're hearing about somebody who's making statements about suicide. We're in that position to be, is this a crisis and is this something that I need to escalate? The de-escalation tactics again are that connectedness, that graciousness, that acknowledgement, and the willingness and being there for help. One of the common places that people say is like, oh, I don't want to be a burden to you. I don't want to say that. There is a tactic that allows, and the data continues to show that an individual who is helping somebody else actually doesn't feel like a burden. They actually feel excited, connected, and a great sense of worth. It may actually be a gift for us to be able to help somebody when they're really, really struggling with something that is worth our help. And reminding them of that can sometimes go a long way in saying, this isn't actually a burden to me. This is something that if you're willing and trusting me and showing how I love you, you love me, that we're connected in a way to be able to support each other, this may actually be a gift that to me, something that you're able to give to me in order for me to help you with. And the data in that type of set does seem to bear this out, where individuals who were in that position tend to feel less burdened and actually would be more burdened if they didn't ask and then should something negative happen. So the burden of not asking may actually be higher than asking. But again, we've got to be prepared to be able to do this. So when do we ask individuals? As we may see some warning signs, increase in alcohol or drug use. It may be a sign that somebody's not effectively coping with something that's going on. They're acting outside of their normal, right? It could also be an escalation where now a new problem is coming up, and that new problem starts to carry its own risk of suicide, right? So the addiction. Increased aggressive behavior. Suicide is in and of itself a self-aggressive and can sometimes reflect tremendous anger. So anger directed at ourselves sometimes does get manifested in anger elsewhere. Withdrawal from friends, family, community, again, not acting like themselves, withdrawing, showcasing in behaviors, the loneliness, the disconnection. Mood swings, where, again, that there's that sullenness, sadness, and then they may have the escalation. Impulsive or reckless behavior. When somebody's really not thinking about their life worth living, they may cease to engage in certain practices that are there to protect their future. And the lack of protection of their future may include some of those impulsive, reckless behavior. They may agitation, the recurrence of previous problems. So individuals who are carrying around previous mental health conditions, there may be a return of the previous issues. I'll say one last piece here as far as a warning sign. Sudden changes tend to be difficult, tend to be challenging, and if an individual all of a sudden suddenly seems like they've been very, very agitated, very concerned, very issue, and all of a sudden seems 100% at peace, it may also be an opportunity to ask them whether something happened. There are times where the agitation, aggression, annoyance, difficulties, because they know that this is not a thought that they want to achieve, but they simultaneously don't know that they want to live the way that their life is starting to pan out right now. They're not sure. And that not sureness is creating tension. Sometimes we see the peace because people are like, okay, I'm good. I'm going to be able to tolerate this and everything's all right. And that thing was not there. It usually doesn't come with such a sense of peace of saying like, oh, everything's fine right now. Because I mean, there was stuff that was really wrong. So individuals sometimes make the decision that they're going to do this, and they then become at peace with the decision to attempt suicide, and it may get misattributed as they're looking better, but they actually were looking better because they made a decision for something that's worse. And so if your gut is still saying something doesn't seem right, even though they're appearing and everything's saying, there is still an opportunity to ask again and say, did you change your mind about something? And hear where things are simultaneously, getting them to a professional and say, I know that they're looking way better, but something just doesn't seem right here. Or I know you were talking to them and they're saying that they're going to go home and everything looks tremendously better. I'm just not sure. Can you please help me understand? And then again, engaging in that professional conversation. So some of the these warning signs, some of the additional warning behaviors that you may see: giving away possessions, tying up loose ends, new life insurance policy, higher life insurance policy, increase in beneficiaries that seem to be coming out of the blue while simultaneously engaging in these things that don't really seem connected with the timing that somebody would engage with this, saying goodbye, giving away prized possessions, and then the most egregious, which is the things that the person's doing seems like they're starting to stockpile things that are dangerous to themselves, dangerous things, pills, ropes, weapons, new weapons, for sure. Yeah, just gonna pause there. Children and adolescents may be different because of the way that they engage with some limitations in the way that they engage. One of the biggest areas here is changing baseline. So you see that there's a sudden change in circumstances. The change could be at home. It could be with interaction. It could be with engagement. It could be with their friend circle or now lack of friend circle. Changes at school, changes in their school performance, school activities, the things they used to like doing, they no longer like to do. Preoccupation with death, that may also showcase in the way that they're searching media and the media that they're consuming. Identification, feeling of hopelessness, that things don't matter, that some of the things that they felt were really important or the goals that they had no longer changing. Again, giving away their possessions may look different. The things that they held on to as theirs and solely theirs, now not only willing to share, but is now starting to give them away. As well as seeing some of those significant changes of mood. And irritability in children is something that certainly can come up. One of the things that we have to be aware of when we think about children and adolescents is that there's a development pattern that occurs. And so when I'm saying that there are sudden changes, this is in the context of also the normal human development pattern. It is appropriate for me to not want to be around my parents at certain periods of time, and it doesn't mean that I'm withdrawing or somehow excluding them. In having my own personal private time is important, and simultaneously, there are individuals that'll be able to evaluate that and say, yeah, but they're still connected in the way that they have. That's pretty normal for what their development. Asking pediatrician, asking any professionals on guidance of what seems to be normal and not, really important. And then we see generational changes as well, where things, and one of the difficulties is there are times where we put ourselves in another person's shoes and says, what would I think if I was going through that particular thing? When it comes to children and adolescents, adult in a different generational, in different generational growth, may put themselves in the shoes of a child, not recognizing the impact that social media, online friends, internet-based commenting, as well as other worse things than just commenting when we start thinking about social media bullying, internet bullying, and in-person bullying. All of these things simultaneously may really require us to try to put ourselves in the child's shoes while also really understanding what the child's shoes are. And so an opportunity for us to understand what the child's dealing with, not just in the event, but also their emotion related to that event without trying to dismiss it. Because my social media engagement and the way that I see my social media friends may be very different than my teenage niece and the type of engagement that she has, and the way that she sees that social media identity as her identity, that may be very different than mine. And so just again, that allowing that patience, that non-judgmental, the grace for us to be able to really get the sense to connect with that individual from their perspective on what they're going through. The statements of saying, but this doesn't matter, may be I know this doesn't matter to you, but this really matters to me, and maybe a statement relates to that isolation, which is I'm alone in the way I feel this way, because when I say this doesn't matter, I know you're going to say this doesn't matter. And that again can create that departure, saying, well, if it matters to you, it matters to me. I would like to know how this is really important to you. And if it really didn't matter, can you please tell me how I'm kind of confused right now, because you really seem upset about this. And it does seem that something really does matter to you. And so maybe we don't have to pay attention to the ones that you're saying doesn't. Can you really help me understand what does matter? What is important related to this? Because I can see you're hurting. So it can kind of get to that piece. We have help that's always available, and some of the resources we have, the highest crisis emergency hotline 911, get somebody emergency right to the home. We have online 988. There are a lot of community mental health clinics that operate with chat-oriented services. There is in-person and virtual treatment options for people who are having a condition. Therapists, medication management, as well as the full complement of neurologic and medical services connected under mental health benefit, under the medical benefit. But when we're thinking about, well, want to get help, I want to be a help, and I want to make sure that they're getting the right help, is again, that asking. It's about that connection, that listening, our own understanding that we're going to be managing ourselves while listening to somebody who we love and care about, that we're asking them the question, to start giving us a picture where they may have been so afraid to say it, that they're starting to say it, and it may make me afraid as well. And I want to manage my fear through my ability to cope so that I can help effectively address this person's without trying to erase it or make it go away. Staying with that individual and making sure that we're not leaving them alone when they're in that critical state, and really creating an opportunity for that safety through securing any immediate lethal means, and then additionally creating steps longer to do anything, more time, more difficulty in order to immediately act on something, in order to really give that person opportunities to triple check about how serious they are, and then calling the hotlines and getting that immediate help. I want to highlight that there are many areas that have increased specialty support through first responders in engaging with individuals who are at risk of a mental health condition and at risk of suicide. You may have heard of mental health first aid. You may have also heard of mental health liaisons that some first responder teams may be operating with, that will allow a specialist to do a more comprehensive assessment to determine whether somebody's going into the hospital or not. The opportunity there is to be able to engage, that we're not further removing somebody away from a place that they may actually feel comfortable into a place that they may feel less comfortable. Hospital-based ERs and the assessments through hospital, very critical. And when we're thinking safety first, there's sometimes no way around it. It doesn't mean it's the most comfortable. It doesn't mean it's the most low stress with everything else that's happening in emergency departments. And so it's really about trying to keep that balance. Safety first always rules. And there are times where individuals will have to go through what in Florida is the Mental Health Act called the Baker Act. Every state has one where individuals who are in danger to themselves, others, or at risk of neglect would have a statute that allows them to have an assessment to determine whether mental health condition is presented, and the way that condition can be effectively managed through an assessment. The assessment is not in time, just like one assessment. It may take several, sometimes here in Florida, 72 hours. In order to determine. So there's some leeway there to say, like, I'm going to really make sure that there isn't a mental condition here. And if there is, I want to really have enough time to make sure that I'm treating it before making the next judgment on whether this person's safe to go out. And there are ways that that people can always sign themselves into the hospital. So just because somebody's taken the hospital and said, no, I don't want to go, if they make the decision as they're sitting there, as they're talking to somebody and saying, like, shit, I really need to be here, there are opportunities for them to sign themselves in. So taking care of ourselves is critically important. Want to make sure that we are talking to people that we love and trust. That could include our friends, family, our spiritual leaders, as well as our mental health providers. We want to be able to use the resources available for in a near crisis or crisis using 998 or 911 in order to make sure that we are being our own advocate for safety first. we want to make sure that we're staying connected. We want to stay connected to the social and support systems that are there for us, as well as those individuals that are providing us our direct treatment, while keeping them apprised of the things that are going on. And of course, have to say it again and again, being cognizant that separating ourselves from immediately lethal means and highly risky circumstances, asking for individuals' help, and creating those checks and balances to say, if I know that I'm struggling, I'm going to place and gift an individual in order to help me by working with them and allowing them the opportunity to help keep me safe. They may take care of my medications. We may remove all firearms from the home, even if it's not a legal thing. This is just a safety thing. Removing it until I'm in a better place to evaluate the safety of that being back in my home. So we've got the hope. I mean, it took this part of the slide just a little bit over on where I wanted to be. So hope can be an acronym for help, optimism, persistence, and evolution. The help can be there in order for us to recognize that hopelessness can be temporary. That with appropriate help, we may be able to start to get a more broad perspective on where things are and how problems may fit in our life, and remind ourselves of a lot of the strengths that we've demonstrated across all of our lives and the resilience that we've shown through previous problems in order to say that we too can get through this as well. There are, in optimism, allows us to see options. There's a Yahoo is another acronym here that says you always have other options. And so if we're going to maintain the optimism of saying Yahoo, we may also see the optimism that there are options that may actually start creating a pathway of recovery. And that through our resilience, that recovery may allow us to have not the same good life, but another good life in the aftermath of some critical things. The persistence is also to ensure that we're being persistent in addressing those things that need to be addressed, and that providers are a critical factor there in order to provide us the assessments in order to diagnose any conditions, the treatment plans in order to be able to improve that pathway to recovery, as well as to be able to iterate when new circumstances occur, and to really be a source of that we can rely on for that caring, compassionate conversations moving forward. And then the ease, evolution, and through that engaging, empathizing, through the active listening, we may be able to evolve our understanding of our own connectedness in the way that individuals are connected to us, as well as evolving our options, our opportunities, and really evolving our life in a way that is able to continue to showcase our worth in the way that we engage on the day-to-day. We have resources here, and the 988 is one that was put forth by the federal government is across all of the United States as a hotline, 24 hours a day, 7 days a week. We do have here at Lucet a suicide awareness and conversation toolkit that's available on our website and through link. The National Alliance of Mental Health is called NAMI. They have a helpline that is to text, and also provide a wealth of resources, including support groups, virtual support groups, and resources for even in-person support groups for individuals who, as supports for family and friends who may have had somebody tragically die by suicide, or individuals who have a history of struggling with suicide in order to be able to provide that support. We have the American Foundation for Suicide Prevention is a resource as well, and one of those national organizations. You'll have the other ones there. I just wanted to highlight those few there. Once again, a plug for the Lucet Suicide Awareness and Conversion Toolkit that's there in the middle. Plug for the Suicide Prevention Lifeline there, 988, and NAMI text line 62640.
Okay.
That's it. That's what I got.
That's a lot, Dr. Ligas. Thank you so much. So we did have some questions come in. So first question came in, are there any specific symptoms, signs, or body language that can be identified to help prevent someone from committing suicide?
So a change in body language that seems to speak to aggression, that's one. The other one is, so the hard part is, and I tried to get it in the slide, where suicide is kind of nuanced and complicated. Sometimes it's the pulling away. Because I said suicide is aggressive, if you are seeing somebody that appears very aggressive, well, certainly behaviors like, I'm going to get a gun, I am going to a medicine cabinet, you can't stop me, this is what I'm going to do, those type of behaviors, I'm not talking about those we're talking, that's crisis, we're getting all hands on deck, we're going to prevent their access, or we're going to get somebody involved in order to intervene. I think the one that you were asking is more of that like nuanced one. So I'll say that the departure from normal, where an individual seems more aggressive, and include impulsive, or more of that withdrawn, isolative, disconnected, with that sense, and sometimes it's an internal piece, but they may be saying things like hopeless, not worth, this is not worth it, I can't really see it going on, those type of behaviors. Notice it does, each one of these things is including some type of a talk track or speech, because we can't read people's minds. And the hard part when it comes to behaviors is, as a psychiatrist, I can have any behavior presented to me, and I can create multiple different pathways on what's driving that behavior. And so it's really about teasing it out, which also means if you are concerned, being clear on what behaviors you're seeing, being clear in communicating that to any professionals that are involved in order for them to be addressed.
Okay. Next question from a mom. I have a teenager, and I feel that I get confused with what is a teen regular attitude and if suicide is there. Like you said, a teen not wanting to hang out with their mom is normal, but what would be not normal? He's a boy also, and this is more difficult for me.
That's a really, really tough question for me to answer in this format. I think, so there is an opportunity, especially with the teenager, to ask him what's going on, saying that he doesn't want to hang out with you, and really having that tolerability to understand the role that you would play in their social dynamic. Right? I'm sure that there's polarities that we can see where an individual that doesn't love their mother and never had a good, strong attachment with a mom is very, very at risk and may have certain problems, whereas an overly attached, and sometimes they were even called certain pejorative terms, overly attached with a caregiver, that may also be a problem. And so then normal is not a one place, and that's one of the difficulties as a psychiatrist. It's not like that one little tiny exact space right there is normal. Normal is kind of in this like broad range. And sometimes even individuals may float like all to one direction and then kind of bounce back into a more kind of consistent central normal. Having a conversation with them, having any, and being able to then also be open and honest with them too about your concerns, which is, you used to like hanging out with me. I felt like it was very close. I am worried that you're kind of separating from me and disconnecting from me, and that I'm losing touch with you, who I love and care about. I was wondering if you can tell me what's going on with that, and then really being able to again have that tolerability, that not easy conversations, right? To be able to have that tolerability, and if you can't do that, being able to seek resources in order to help facilitate that conversation, especially if there's any worry whatsoever. Second part is also you can ask friends. Have an opportunity to ask friends or friends' families to say like, hey, how is that going? Because sometimes individuals will model what their friend group is, and then you'll start to get a sense of like, in this pocket of this group of individuals, what do they think normal is? And what is that being driven by?
Okay.
Hey,
Debbie, yeah, go ahead, Debbie.
Yeah. Hi, this is Debbie Galazari. I'm at LCSW as well, and and wanted to hopefully maybe add just another kind of view. I think just like Dr. Ligas was mentioning is that sometimes it's not your own mom view, but sometimes looking at their other interactions. So like if they are withdrawing from their friends that they normally interacted with, if they were really great in school and then suddenly that seems to be a change in their behavior, or other signs could be, you can't say sleep because teens love their sleep. So you can't always use that as a guide to reflect, are they sleeping too much? But it's kind of knowing your own kid and kind of what was their personality at one time. They might be different with you as their parent because they feel safe and supported in that environment. But if that behavior is also or is a little bit different in their other social situations, family, sports, other friends, school, that might be a sign of just asking that question, just like it was mentioned, like, hey, you seem a little different, what's going on? You can talk to me, and just helping in that way.
Perfect. Thank you. Okay, next question. Is someone who is bipolar more likely to contemplate suicide?
Bipolar is one of those conditions that compared to not having that condition, there's a higher risk of suicide. Higher risk of suicide attempts and also higher risk of completed suicide. And so the simple answer is yes. The hard answer is that not everybody who has bipolar is going to think about suicide. Suicide is not a requirement in order to diagnose somebody with bipolar. I will say this, that rapid changes in mood, especially for somebody who's on the manic to then the crash depressed, that rapid change is one of the higher risk times for somebody with bipolar to think about suicide. So it kind of fits this general sense of what's the normal, what's the change, how big is this change? And so somebody who went way up abnormally high to abnormally down, that big change, that time frame for that change may be the highest risk. If you are, and for anybody seeing concerns with somebody diagnosed with a bipolar condition and seeing the mood swings that are outside of that person's normal, being able to ask them questions about are they taking their medications? Are they having conversations related to that? Are they even aware of that? And then being able to ask that question of are they thinking about it? And is there any way that we can help? Can go a long way.
Okay. Question came in. Gambling addiction has the highest suicide rate of any addiction. 1 in 5 of those with gambling addiction attempt suicide. This addiction is rapidly growing due to the increase in online gambling, particularly in the 18 to 24 male subgroup. What is Lucet doing to identify and treat those with gambling addiction?
So Lucet, we don't provide direct treatment. We're a partner with Florida Blue in managing the mental health benefit. I will say that for individuals who are connected with Florida Blue and who have Lucet as their partner for behavioral health, reaching out to us, inquiring about resources that include specific treatment professionals to address gambling addiction, that is something that we highlight in treaters' skill sets. So that we can be able to effectively match a particular condition with the right people to provide that treatment.
Okay. Did you have something else you wanted to say on that?
No.
Okay.
No, I'm good.
So listen, there are a couple questions we didn't get to, but we are really out of time. So Dr. Ligas, I'll email those questions to you. If you could answer them, then tomorrow I will send out a follow-up email to everyone who's in the webinar with the recording link and the resources that you mentioned too, so that everybody has those. We also have some wonderful tip sheets that Lucet put together that I'll include in the handout. Thank you so much, Dr. Ligas. If Those of you who are in the room, if you could point your camera to the QR code or click on the survey evaluation, we would appreciate it if you would give us feedback. So thank you, Dr. Ligas, for sharing your expertise with us today. We so appreciate you. And thank you, everyone, and have a great rest of your day.
Bye, everybody.